My first lecture it will provide you some basic information about the pelvic ring injury, and for sure, I believe that you are already have some experience, so I do not intend to provide the basic lecture about classification and radiology. I think it's not necessary. So we may come to just to evaluate, to review, to evaluate the pelvic radiographic studies and to classify the pelvic fracture and assess its stability in some interesting point. Usually AP will provide us enough information, and usually this is the only X-ray that we will get at the emergency room. So look at the AP view, you can get the information at the sacrum, at the pelvic ring, from the back to the front, from the back to the front. Every time look at it, just remind yourself that you need a quality AP view. What is the quality AP view? The quality AP view is the X-ray that is really the AP. So how to identify that? You need to make sure that when you look at the lumbar spine, the lower lumbar spine is usually involved in the X-ray L4 and L5. Spinal process should be in the midline, and the distance from the spinal process to the pedicle should be equal. This is the quality X-ray of the pelvis. So when you are certain that this is the true AP view, now you look at this, you can see the symphysis is a bit to the left side, which means that in this case, the patient has the external rotation of the left hemipelvis. And you can confirm again by looking. Looking at the width of the ilium. This is to confirm the external rotation. When the hemipelvic external rotate, you will see that the left hemipelvis become wider, open like that. Another view that we use is the inlet view. Inlet view is the X-ray to see the pelvic cavity, the true pelvis boundary. Here, you see, look at the symmetrical of the pelvic ring, and again, if you can see that deviation over either side, it means that there is an external or internal rotation of the pelvic ring. What about the true inlet? The inlet that we use in the X-ray usually is done by the technician. The true inlet is the X-ray that I would like to emphasize a little bit, because we really need this for the percutaneous screw fixation. The true inlet view is the inlet view that we try to tilt the II like this in order to get the S1, S2, and S3 in the same level. This is the true pelvic inlet that you really need when you do the percutaneous screw fixation of the iliosacral screw or the sacral fracture. Look at the difference between these two. This is the inlet view that usually you will get from the emergency room or from the radiologist, and this is the true inlet that you need to have in the operating room when you decide to do the iliosacral screw or the sacral screw percutaneously. You can see the difference between the left side, which you still can see that the tilting of the X-ray tube is not enough compared to the right side. The outlet view as well. The outlet view is the X-ray that usually this is the true AP view of the sacrum. You will get a lot of information from the sacrum in the outlet view. But unfortunately, most of the patients will have the bowel dilatation, a lot of gas, and I would say that most of the case with the pelvic injury, the outlet view might not provide enough information about the sacrum because of the bowel gas. Again, this is the true outlet. What is the difference When we try to do the percutaneous screw fixation, we need a true outlet of the sacrum, which you're supposed to get the upper border of the pubic body in line with the S2 screw. And this is the ideal outlet view that we need intraoperatively. Again, this is intended to show you the difference that the left side is the image that you usually get from the emergency room, and the right side is the ideal image that we need before we put the screw. You can see this is the S1 foramen and this is the S2 foramen. You need to look at this and you need to identify this landmark very clearly before you going to put the screw. Otherwise, you run the risk to injure to the nerve itself. CT scan. I think needless to say that it is very important nowadays, and I think the CT trauma body nowadays become standard. Sometimes you even do not get the AP pelvic. For example, in my practice nowadays, the first radiographic study that I got in hand is the CT scan, because sometimes they just do the pelvic, the CT trauma body, and then we just have a chance to look at the CT scan. And it is very useful. For example, if you look at this case, you can see that there is some injury to the pelvic ring. You can see the separation at the pubic symphysis. For sure, there will be some injury to the backside. CT scan shows you very clearly that there is the sacrum over the left side that show the posterior ring injury. This is another example. You can see that there is some fracture. There is some fracture over the left pubic lamine. Over the left side, it doesn't clear whether there is any injury, but if you look at the CT scan, you can see the fracture of the PSIS, which is typically this is the LC2 fracture, which you will never get this information from just the X-ray. Apart from information from the bone, information of the soft tissue also is very important. For example, you may need to look at this, and you can see both the femoral artery and femoral vein very close to the pubic lamine in case that you plan to put the screw right there to review the CT scan before your pre-op planning is very useful as well. Or another useful image from the CT scan is the lateral view. We do not do the lateral X-ray of the pelvic routinely. This is not in the practice, but you always get the information from the sagittal view of the CAT scan, and this is the only view that you can see the sacral fracture in the zone 2. And also, when you look at this, you're supposed to look at the nerve as well. Where is it? Where is the nerve? The L5 nerve root is somewhere here. That's it, the L5 nerve root, and this is the S1 nerve root that you usually can identify when you look at the cross-section of the CAT scan. And here you can see that there is a fragment. The fragment here in the S1 that trap the S1 nerve root, and this is where you may need to attack during the surgery as well. So this is the information that you will get from the CAT scan rather than just the bone itself. Also, the malleolabily, you can get the malleolabily image like a hyperdense area subcutaneously that remind you that there might be the deglobing injury in the pelvic as well. And the 3D rendering also provide you the information, both useful for pre-op planning and is useful to explain to the patient or the family as well. Another thing that I may need to talk to a little bit is to identify the sacral dysmorphism. Sacral dysmorphism is the shape of the sacral area that doesn't look like the normal sacral area. This is I think this has some relation to what we call the transitional vertebra. You know the transitional vertebra that in the past we just use a lumbarization or sacralization. In my opinion, this is part of what we call the sacralization. And you need to identify this because in case of the sacral dysmorphism, the L5 nerve root is in the position that have some risk when you decide to put the screw. This is the recess. This is the recess of the S1 that you can see that very close to the trajectory. And just to show you a brief idea that you need to identify the dysmorphic sacrum for the pre-op planning. Now a brief talk about the pelvic calcification. For the AO calcification is type A, B, C, but we always use the Young and Burgess, and Young and Burgess is the most popular use. This is a mechanical based classification, and in this course we will use the Young and Burgess classification as well. APC 1, 2, 3, LC 1, 2, 3, and vertical shear. APC 2 and 3 are rotational unstable pattern. Vertical shear is both rotational and vertically unstable. These are the group that usually need a surgical stabilization. APC1 and LC1 generally a stable pattern, but we may need to consider the fixation in case that you have associated abdominal injury and the general surgeon have to go for the laparotomy, so we may just do the fixation right away. Or there is some protruding fragment in the perineum, or the patient has refractory pain. If the stability of pelvis is in doubt, then we consider what we call the EUA. For example, if you look at this, I think sometimes it's very difficult to differentiate, to know exactly whether there is a posterior injury or not, just looking at the X-ray or even the CT scan. So the question is that which APC1 and actually what we call the outcount APC2, or it's APC1 that really have the posterior injury, but you do not see from the X-ray. Or is there any APC2 that in general is just the anterior instability, but they really need the posterior stability or not? Which LC1 is considered unstable? So this is the publication in 2011 that Saki proposed the examination under anesthesia, which you may look at this literature and to get more information. This is what they show you. Internal rotation stress full load. You can see that when you do the stress full load, looking at the C and D, you can see the difference. And if you have excessive internal rotation instability, then you consider the fixation. So to answer this question from this publication, when they do the EUA, it found out that half of the case that they believe it is the APC, but actually it's the outcount APC2 that requires this internal fixation. For the APC2 as well, whether they need the posterior supplementary fixation or not, from this literature it showed that almost 40% that require the supplemental ilosacral screw fixation. And for the LC1 that we consider as stable, this literature showed that about 35% was treated with the fixation as well. So EUA is very useful technique to evaluate the stability. In summary, we need to get the most information from the X-ray, not just the bone, not just the osteology, but for the soft tissue as well. Look for the symmetry and a good quality X-ray. Aware of the sacral dysmorphism. We will talk about this more in the discussion. Classify the type of pelvic fracture to guide the most appropriate treatment. I will finish with this X-ray. You can see this is the X-ray that you can see. The left one look quite stable LC. The left side, when the surgeon did the stress test, you can see that there is an internal rotation, and the surgeon decided to put the screw. This X-ray I took from the operating room in 2003, 20 years ago. And the surgeon is Dr. Shiplaut. I have a chance to stay with him at that time. He is the one to propose the technique of the percutaneous ileal scale screw fixation. Thank you very much.